What's going on, guys, and welcome back to the world's okayest physical therapist podcast, hosted by me, Dr. H. Today, in case you can't tell, my voice is a little bit weak, so if I'm pausing a lot, it's because I am drinking some water or some coffee to try and keep my voice in the game. I apologize. Please don't forget to like, comment, subscribe, share this with everybody you know, as I am learning to navigate the Byzantine, labyrinthine, constantly changing and modifying American healthcare system in order for us to all learn a little bit more together to better navigate it. That way we know who to go to when we have what issues, how to communicate to those people, and we can just be a more educated population in order to better take care of ourselves and others. Ways that you can support the channel is, of course, Patreon, which is the best way to support. I put all the podcast episodes on there before they're released on Spotify, Rumble, and YouTube. Also, you can check out this 15% off link from 10,000. They were nice enough to give me a referral link for me to share with my friends and people here. And so this will get you 15% off on orders of $60 or more, which puts you right around at $9. I love their shorts. I'm wearing a pair right now. I'm actually always wearing a pair if I'm not at work where I have to wear pants. So if I can, I'm going to be wearing their shorts. And this is a picture of the shorts that I bought most recently. So let us now move into sciatica and the why of this episode. The why is that the back is the most common injury or region that a physical therapist will see in the clinic, which means it's the number one reason why people are coming into the physical therapy clinic, which means there's a lot of people out there that have some sort of back pain or issue. Knowing how to talk to a physical therapist or healthcare professional about your pain, what the conditions are, what the issues are, what the symptoms are and the hallmarks of certain conditions that you're experiencing will help the PT and the person who have the issue better arrive at an effective treatment plan and understanding the likely key contributing factors. Put shortly, knowing more conditions and the symptoms associated with those conditions helps everybody better navigate them and tease out what's actually going on or what multiple things are going on. The real reason why I'm doing this is one of the people that I've seen, one of the people that I saw in the clinic recently was misdiagnosed with this. And it was such an easy tell to know that they didn't have it. The fact that another physical therapist got this wrong was frustrating enough to me to make a podcast episode. So what is sciatica? Sciatica is, by definition, is irritation or compression of the sciatic nerve. Now, this can be from, it says here, herniated discs, bulging discs, stenosis, which is narrowing of the spinal column. So it's where the spinal cord lives. Sometimes there's narrowing of that and it can lead to symptoms. Tightness and deep gluteal muscles, what it's basically saying there is you can have tightness of like the glute minimus, the piriformis, or other structures deep in the hip that contribute. I've also seen paralumbar muscles that get involved that can cause some compression and issues there. The symptoms are usually described as radiating pain down the leg. Now, this is different than numbness and tingling. Okay, pain specifically that runs down the leg in a very specific pattern. Now, I cannot show you those patterns because those patterns are all copyrighted, and I couldn't find any that were available on public domain or for free. But if you go into Google right now and you type in piriformis pain referral pattern, or you type in glute minimus pain referral pattern, glute med pain referral pattern. If you just type in any muscle followed by pain referral pattern, you'll be able to get a map of what generally it looks like when that muscle has a trigger point or is in pain or is strained. So pain that runs down the leg, numbness, tingling, weakness, usually in the predictable nerve pattern because it's the sciatic nerve that's impacted. This is different from just low back pain. It's nerve related. So again, if it's just pain in your low back, that's low back pain. A lot of times that can be just the QL, the quadratus lumborum. But this is pain that runs down the leg, often with numbness, tingling, weakness, and usually in a very specific pattern. It's not always global leg weakness. So this is a picture of the sciatic nerve being trapped by some fascia. This one was public domain, so I was able to use this. And that is the glute max that has been cut away right here. So that's that ridge, and then underneath you can see the sciatic nerve comes out right underneath that piriformis, and then right over what's called the P-go-go-Q. That's what I call them. It's a whole bunch of small hip muscles, very deep hip muscles. And so what can happen is a lot of times if the piriformis gets tight or has a big trigger point, it will squeeze down on that sciatic nerve and cause pain down the leg, as well as numbness and tingling and other sensations. And this is a good point to pause and say, if you are having any numbness, tingling, pain, throbbing, or anything like that with physical activity, you should stop and you should talk to a medical professional, because it's a sign that something other than exercise is going on. Numbness and tingling is not normal. Pain running down your leg is not normal. Throbbing in your leg is not normal, right? All that should go without saying. And it should also go without saying, this isn't medical advice right now. This is just me educating on a condition. But numbness and tingling, throbbing, pain running down the leg, all of that's a sign to go and talk to a medical professional. So the common sites of impingement, like I was saying, were piriformis, quadratus lumborum. The hamstring is also a common one, and even all the way down into the gastroc, you can have a little bit of impingement. And why is this important? Because impingement in any part in the system is going to keep the sciatic nerve from moving the way that it wants to. It wants to move like a wet spaghetti noodle through your tissues to reach its end destination, which is all the way down the foot, to provide innervation all the way down there. And it wants to move and glide through the muscles freely without being constrained. And so any impingement, which is just a squeeze on that muscle, anywhere along the chain can cause issues, can cause that numbness, that tingling, that tension, that pain. So that's why I wrote here, the pain can radiate to a whole bunch of different places, but tension anywhere throughout the system is likely going to be a target physical therapy that they're going to address, because they don't want any tension in the system at all. They want that nerve to be as free as possible. So what is sciatica confused with? Oftentimes it's confused with hamstring strain, and that right there is where you're seeing that pain. I have pain down my leg. What else could it be? It could be a hamstring strain. It could be a glute strain. It could be a low back muscle strain that's radiating all the way down. The very first thing that it can be confused with is strains. Pain in the back of the thigh that can mimic nerve pain. The second thing is piriformis syndrome. I see this all the time in the clinic, all the time. Piriformis syndrome specifically, not it being confused. Piriformis syndrome is where the sciatic nerve is compressed by the piriformis muscle and not the lumbar spine. So when we go back up and we take a look at the key contributing things, herniated disc, stenosis, anything coming from the lumbar spine, QL tightness, no. This is one specific muscle, the piriformis, that is very tight, that is hugging down on that nerve and not letting it move. Very, very common, very easy to figure out pretty quickly. Hip joint pathology. If you have pain in the hip joint, either from a labral tear, arthritis, that's what OA stands for, arthritis, there's a whole host of things that you go down. Hip pain or SI joint pain, all of that can refer pain into the thigh or the buttock, and that can also mimic that sciatic pain just a little bit. Vascular issues. The leg pain can also be due to vascular issues that can sometimes also appear like sciatica. But usually the presentation and how it's brought on is what's going to be different. Facet joint pain or sacroiliac joint dysfunction, like I said, that may radiate, but it's not true sciatic involvement, because both of those things are a little bit different. They can focus more on like nerve roots instead of the actual sciatic nerve itself. And again, for facet joint pain and stuff, you might be asking, what is that? That's the lumbar spine. That's kind of beyond the purview of this podcast episode. But all it's saying is pain originating from the lumbar spine and pain originating from the sacroiliac joint, which is where your sacrum and your pelvis meet, right? So both of those, it would be like joint pain that's different from radiating down the leg pain. And that's why it's different, right? Joint pain versus radiating pain down the leg with numbness and tingling. So how does a PT tell the difference? Onset of pain, right? There's a whole pattern of things that are going to make sense. The pattern of pain, for example, the activities that make it worse, that make it better, Also, the distribution of the pain. So is the pain running down the anterior part of the thigh, the posterior part of the thigh? Is it only in the glute? Is it only in the low back? All of that is a bunch of check boxes for the PT to be like, oh, okay, I see what's shaping up here. I can see what this is. And then the physical exam itself, right? So we call the patient history the subjective. It's the part that you tell the physical therapist in about the first 5 to 10 minutes of your session. The physical exam portion is going to be the part where they go and they do special testings like straight leg raises, looking for nerve irritation. So they're going to point the toes in different directions and see if it's specific branches of the sciatic nerve that's being impinged. Slump test, one of my favorite tests of all time, is going to go in there and look for neural tension. Piriformis special testing, that's going to be the one we're going to see, is the piriformis tight, and is that's what hugging down on that sciatic nerve, is that what's reproducing these things. And then differentiating muscle pain versus nerve pain. That's a lot of patient education, and that's going to be done from palpation of the PT going over their fingers, strength testing, and then checking mobility. All of that is going to be how the PT effectively goes in there and says, okay, yep, you're having numbness and tingling going down your leg, but the minute I went in there and released all that neurotension of your piriformis, boom, it was gone. So therefore, we can safely assume the piriformis was likely the largely contributing factor to your sciatic pain. And now that we've released that piriformis, there is no pain and any motion. There's no numbness, no tingling anywhere. We can safely assume, in the case of this hypothetical situation that is not medical advice, the piriformis was the only contributing muscle that was tight. And we also know that your hip external rotators in this case are also weak, so which would be a piriformis. So we know that your piriformis is likely it's tight and it's weak and it's hugging down on that sciatic nerve, contributing to your nerve pain. Right, so that's a really easy hypothetical that the PT might arrive at after doing their evaluation. The red flags, the things that the PT are going to look out for that they should ask, is if there's any bowel or bladder issues. That's exactly what it sounds like. It's inability to go or inability to control going at all. Progressive weakness, which is going to be like you've been noticing you've been getting weaker. The numbness and tingling in a very specific pattern called saddle anesthesia. All of that are things that the PT is looking for, because that means that they're going to refer you back and say something other than sciatica is going on and it's a more serious condition that needs more advanced evaluation and possibly intervention beyond PT. So that is how the PT is going to go in there. And unfortunately, that is something that is very clinic specific, meaning it occurs in the clinic. It's not something that can be discussed through on a podcast very effectively. It's something that each PT approaches a little bit different. They have their tools in their tool belt, their special testing and their range of motion and strength assessments that more quickly lead them one way or the other to figure out what's going on. And this, actually, I'll camp out on for just a second, because when the specific person came into the clinic that I'm thinking of, they were seen for about 30 minutes. The PT had only asked them some general specific questions: subjective onset of pain, activities make it worse, blah, blah, blah. Went in and did their evaluation, and they concluded that this person had sciatic nerve impingement. And when I did my subjective and I did my objective evaluation, the patient had only ever had pain in the low back, and only on the right side, with no numbness, no tingling, no radiating pain down the leg. There was weakness, but it didn't follow any specific pattern. In fact, it was mostly just kind of generalized weakness of the hip extensors and the hip abductors because of the pain more than anything. It wasn't that it was actually weak. It's just the pain of having to recruit the QL in the position where I had them, and it was what actually stopped them. And then, of course, when I had him do side bending, hip hiking, really, really weak there, could barely do it on one side versus was fantastic on the other. So all of that was leading me to, I think that you're actually having some low back strain symptoms here. You're not having any numbness and tingling. It's not radiating down your leg. It's not even radiating into your glute. It's only centralized in your back. You don't have, like I said, any numbness and tingling. You didn't have any bowel or bladder issues, progressive weakness, numbness and tingling. It was really only weak in 2 or 3 muscles and extremely strong everywhere else. And so that led me to thinking, okay, this sounds almost like a muscle strain. This almost sounds like a weakness. Like the mechanism of injury was they were squatting and they felt their back shift just a little bit in one direction, and they felt like there was a little spasm, and it was on the right side. And so I was thinking already QL, and of course I don't want to be biased and put myself in that position of saying it's only going to be the QL, but all of my special testing came back, okay, this is the QL and this is the glute med. It was just overstrained. He never actually trains his lateral glutes. He doesn't train his low back to be able to rotate or accept lateral flexion. He only does what every person does, which is if they do go to the gym, they squat, they deadlift, and they bench press. Right. So that led me to drive my conclusion to come to what it was. But the fact that he didn't have numbness and tingling, he didn't have any pain referring to the hip or the low back. He wasn't even positive for piriformis testing, slump testing, or straight leg testing. And the person that had saw him said, you have sciatica. Right. That right there should be an issue. And if your PT is telling you that you are presenting with some sort of issue that doesn't seem to make sense when you research it, don't forget you can always go somewhere else and get a second opinion. Or you can always ask to see a different PT and say, yeah, this doesn't make sense to me. Right? Which is what he did. He left that clinic that day and came to the different clinic where I'm at and said, I want to see a PT because I need a second opinion. Because after he researched it, he said, none of this makes sense to me. This is not what I think that I have. And after I evaluated him and I did all my special tests looking for sciatica or looking for sciatic nerve impingement, I didn't see it. So all of that to say, a little brief story time. Sometimes PTs get it wrong. Sometimes I get it wrong. That's the whole point, though, is you have a hypothesis. You don't tell somebody that this is the spoken truth. This is exactly what the condition is. You present hypotheses that are provable and disprovable on purpose. That way, if your hypothesis is disproven, hypothesis 1, is disproven, you can shift over to hypothesis number 2 and continue down that train. And then you will usually arrive at the right conclusion eventually, but it's a teamwork between the PT and the patient. The patient has to say, yeah, no, this doesn't sound like anything that I'm having, and nothing you're doing is reproducing anything that I'm saying that I'm having. And then you're like, okay, hypothesis 1 was sciatica. Let's check hypothesis 2, the QL strain. And then everything that you do looking at that QL causes the patient to reproduce their issues. That's a pretty good sign that you might be on the right path, for example. So that's how a PT is supposed to tell the difference. That's sometimes how they get it wrong. But I was just flabbergasted at the degree of wrong that happens there. So treatment for sciatica, sorry for that long tangent. What happens? Well, it depends on the cause. Is it focused on the disc? Is it focused on stenosis? Is it focused on the piriformis, etc.? The thing that is causing the sciatica is what's going to become the focus, right? How you treat a herniated disc with sciatica is going to be different than how you treat a piriformis that's tight that's causing sciatica. So in that case, how you would treat, air quotes, the sciatica is going to depend on what the underlying cause of it is. So in that case, you would be better off asking, how does one treat herniated disc? How does one treat stenosis? How does one treat piriformis syndrome? And that would actually be the true answer. And that's why it depends. Because if you walk in with a sciatic nerve issue, but you have stenosis, your treatment will look different than someone walking in with just piriformis musculoskeletal tightness that's impinging the nerve. But common approaches that are the same across the board: education, of course. Hey, what's causing this and how can we avoid it? What stretches, what movements, walking, etc., what is appropriate for that patient? Nerve glides and flossing are almost all universal. So how do you get the nerve to glide through that tissue? Core stabilization and hip strengthening, again, almost always universal. Almost everyone that has low back pain comes in with a weak core and weak hips, almost without exception. Manual therapy, which is, again, going in and using the hands to relieve tension and trigger points in the muscles. And activity modification. What can you do actively without causing pain that may help benefit the condition and improve range of motion and improve strength? So really what you're looking at is emphasizing those things almost exclusively across the board, no matter what the focus is, but in a patient-specific, evidence-based way. The emphasis, it says here, is to try and do early movement. That is better than prolonged rest, which is becoming a principle in PT. That is, don't sit around and do nothing for weeks on end, because then you'll get more stiff, more tight, and your symptoms won't improve. That, again, is patient specific, though. And while it is a good principle, isn't always universally true, but it is generally more true than false. So this has been the episode of sciatica. What is it? What are different things that can cause it? What are like general treatment things that are pretty effective to help treat it? And then a story to help encourage you all that if you feel like you're not getting the care that you deserve, if you're getting told a story or getting given a label or a syndrome, or you're being told that this is what you meet, and then when you go and research it on yourself and you see this is not lining up with anything that you told them, it doesn't make any sense, and it doesn't actually reflect what you're feeling, you can always go and get a second opinion. Open communication between a patient and physical therapist is critical. And if you feel like you're not being heard and you're being talked over and you're being pushed into a diagnosis that you don't understand, that doesn't make sense, that doesn't actually reflect what you're having, you can always go and get a second opinion. So thank you so much for watching. Please don't forget to like, comment, subscribe, and share. Please consider joining the Patreon. Please also consider buying a pair of 10,000 shorts. Now, everybody stay healthy, stay fit, and stay awesome. And I will catch you all in the next episode.